My project is on ensuring that patients are able to adhere to their treatment plan before the time of discharge. That means both culturally and financially. And I'm mainly going to be talking about the financial side of it. Another thing is this is a very big topic. So, for the purpose of this presentation, I'm going to be mainly covering this from a nursing aspect of it. This would have to go through a lot of different alleys for it to be truly and holistically implemented. You'd have to get doctors on board with it. You'd have to get the hospital executives on board with it. But for the purposes of this presentation, I'm going to be mainly talking about it from a nursing point of view. Let's begin. Why is this important? A big thing that we end up facing is patients can often be readmitted if they fail to adhere to their treatment regimens. And one of the big stipulations with that is patients that are readmitted end up getting a label that we know in healthcare as non-compliant. This is even though that they are going through probably even more hoops than other people go through that do comply, and they still end up with this label because they are not able to afford their medications. Also, healthcare costs in America are high, and are even for the fact that they are high, they're not all that successful compared to other countries. We have a good system, but it's inefficient in the fact that we are paying a lot more for our healthcare than other countries do and aren't seeing the results to match. Again, patients are just labeled as non-compliant for not taking their meds, regardless of what that cause is. A patient that doesn't want to take, let's say, their antipsychotic medications because of their side effects are often thrown in the same class as somebody who doesn't take their apixaban for prevention of clots if they can afford it. And those people are put in the same categories. In my opinion, that's not the right way to look at things. Patients are not receiving the best treatment if they do not have access to their medications. So it doesn't really do any good to prescribe Eliquis, a drug that is notoriously expensive, if the patient's just not going to take it and is not able to afford that drug. An example of that, we have a patient, SS is his initials. He was admitted for AFib and has been prescribed Eliquis as an anticoagulant in prevention of strokes. So SS is in a position to where he does not have health insurance, and the doctor essentially gives him this prescription and says, good luck, you need to go pick up this prescription and take 2 of these a day. So he goes looking around for this medication all day and is at the end unsuccessful because he is just unable to come up with the money, the hundreds of dollars essentially a month, to afford this medication. He's having to choose between take this medication and put food in his kid's mouth. And that's, in my opinion, not acceptable. So, luckily for him, he was able to find a community clinic where they were able to get him a much discounted rate on this medication. But for your average patient, or in your typical case, that may not be the case. That may not be able to happen. How will this change happen? This is a infinitely complex question. There luckily are some guidelines to follow with that, though. One of the biggest ones is Lewin's change model, and this breaks the change of healthcare up into multiple sections. The first one of these is the unfreezing stage. This is preparing for the change. Here you can see before the change happens, there's a lot of resisting factors in the change. This means these are factors that it kind of keeps things as the status quo. Driving factors may be present, but they're probably limited. An example of this would be you have an old model that works but doesn't work quite as effectively as it should. And you have a lot of resisting factors. This is cheap. It's easy to stay the same. This is the way we've always done it. And after, what you end up with is the driving factors and the resisting factors basically end up evening themselves out, preparing to move across the change, essentially. So as a instigator of this change, we are we're tasked with limiting the resisting factors of this change and hyping up and boosting the driving factors of this change. Give me 2 seconds. I'm going to get some water real quick. Sorry about that. My mouth is getting dry. In this case, unfreezing can occur through basically the same thing, presenting factors that show that the way of doing things, essentially not assessing how able the patient is to obtain their medications. Not assessing that is very inefficient, and it will lead to increased rates of readmission in the long term. Again, any way to minimize resisting factors, you got to talk to the leaders of the hospital and convince them that this is a worthwhile change to have, and essentially from that, get their input on how feasible that is, and then begin to implement it further. I have here some examples of some driving factors again. High incidence of readmission, it's an easy one. Pretty straightforward. If your patient doesn't take their meds and adhere to the plan, even if they can't afford it, they will likely end up back in the hospital. Again, if you discharge a patient with medication that they can't afford, or even if it doesn't culturally appeal to them, they won't take it, and they're not going to be satisfied with the care. That's going to drive down business. Resisting factors here still could be this is how we've always done things. Could be an increased workload for the nurses also. Nurses are highly overworked. Introducing a change that could definitely be a positive may not be implemented just because there's so much nurses do every single day that could add to positivity within the hospital environment, but they don't do it just simply because there's not enough time in their day and just because already their workload is so astronomically high. Essentially, just because something is a benefit or has the potential to be a benefit, it's definitely not a guarantee that it will be implemented. So, second stage in Lewis change model is the change stage itself. This is important because it essentially moves from an equilibrium as shown here in the before to a movement stage in the fact that there is more driving factors for the change than there are resisting factors that will cause a movement of that status quo. Essentially, it just tips the balance, and people in this stage, the big thing is people begin to buy into the new way of doing things. They are convinced that the old way was not working, or that this new way offers something that maybe wasn't as possible with the old model. In this case, what you end up with is you end up having to encourage the team members at this point. This means talk to the nursing staff. You need to talk to the floor nurses. Big thing in this point is to be as open and transparent about this new way of doing things as possible. If you're not open and transparent about this, it's probably not going to get anywhere. It's a huge, huge thing. Be aware of any concerns, any questions that these nurses have. Be a voice and be available to answer those questions as they come up. Let's see if I'm missing anything here. Again, the driving factors, let's show that actually. Leadership begins to buy into it. That's a big thing. Again, you need to talk to your leaders, make sure that they're accepting of this change, and essentially talk to the people implementing the change also. In this case, it'd probably be the nurses on the floor. Make sure that they are approving of it also, and even if they're not, answer any questions that could get them to be approving of it. Again, you're going to still have those driving factors. They just need to be addressed and minimized. Not minimized, that's probably not the right word to use there, but spoken for, and kind of the concern needs to be understood, but solutions and kind of ways to mitigate those should be implemented again. Next slide. So the third stage of Lewin's change model is the refreezing stage. Once essentially numbers should be kept throughout this change process showing these stats before. Probably in this case, the good stats to watch for would be total amount of readmissions using the old strategy, as well as patient satisfaction with the treatment before the changes are made also. So you're also going to want to watch those numbers after the changes are made, obviously. And you need to be able to show for this change, for the refreezing to be effective and for the change to be effective itself, you essentially need to show that this change has been beneficial in the terms of either patient satisfaction or readmission, or even just healing in general, just being able to take their meds and just loss of complications. So here you see before, this would be in the actual change stage itself, where there's more driving factors and resisting factors, and in the after stage, you're kind of introducing in back a couple of those resisting factors. In this case, it could be just showing that this change is successful and that it is working on a large scale. So yeah, you see how it's kind of even now and how there's not as many driving factors as there was before, and that kind of introduces that equilibrium again. So in this case, information should be presented to the leaders that pushed for the change, showing a decline in readmission rates, basically all the same stuff. So the nurse should, or the person implementing the change should also talk to the people on the floor that were driving this change and show that this was successful. This is basically to instill confidence in team members that this new way is a better way of doing things, and to hopefully encourage some of those that were a little slower to get on the board for this change. Once you're showing that this is successful, maybe then they will start working toward this change. Driving factors to, in this stage, it's a little different because it's wanting to go back to the old way of doing things. The driving factors that you end up with there is people like the old way of doing things. Driving factors, again, could be also to improve things even more, but you can't be in a constant state of wanting to get better. You will want to get better, but you can't be in a constant state of, we need to uproot things again and change them immediately. You have to get better, see what works long term, and then from there you have to change it again once you come up with a plausible better way of doing it. Because if you end up keeping it changing and keeping it just in constant motion, there'll be no stability. You could end up with some staff resentment. You could actually end up getting worse results if you end up going too far with this. It's just something you need to be careful of. Make the change, make it successful, but don't try to push it too far, at least right away. Resisting factors that could be added in are, again, the confidence that is introduced with the staff, showing that it is successful. Leaders expressing confidence in the changes as well would be a big thing, essentially showing that it is a positive in the long term. Let's go on. And this is again, as stated in the first slide of this show, this is a highly complex situation we're dealing with in this change. And on some of these slides, I highlighted a couple of the driving factors and the resisting factors. There was no way on those slides I could have fit them all in. So here's kind of a general listing of driving and resisting factors throughout this change process. You'll have the higher medication adherence rate, possibly a cheaper system, because if a patient cannot afford Eliquis, they might be prescribed just a standard aspirin, even a clopidogrel. A drug that's cheaper, possibly has more side effects, possibly has more risks associated with it, but at the end of the day, it is adherable. The patient will be able to take that and afford that, even in the short term. So what you end up with there is sustainability. Not everybody can afford Eliquis, even though it is a pretty much objectively better drug in the fact that it has less side effects, less adverse effects. But again, you need to balance that. And I think One of the biggest things is doctors look at what obviously works the best. And I think that's a great way of looking at things, but at the end of the day, they kind of, and nurses too, in a way, kind of lose sight of this is what the patient needs in his everyday life, and this is what he can sustainably have. And I feel like that gets away from a lot of people sometimes. Another big thing, decreased readmission rate, absolutely massive. You hear everybody talking about that like it's the gold standard of everything. If you drop that readmission rate, it is a massive way to make that change happen. It's a proactive approach too. That's a highly beneficial thing in the fact that you're looking at what could go wrong in the treatment plan and you're correcting for that before it gets to the point where they're readmitted and the doctors and everybody is wondering like, well, why didn't this patient do this? Why is he back here for the same exact thing when at the end of the day you weren't proactive and you didn't look for what could have been done differently to keep that from happening. Improved patient-provider trust. If that patient understands that that doctor wants to know about what that patient needs, that relationship is going to be better off than a doctor that just says, here's your Eliquis, good luck. That's not a very good patient-provider relationship. I think using this new system could improve that greatly. That will also result in increased patient satisfaction. That's a pretty simple one also, but it's huge. The more you talk about it, the more you show concern for what the patient needs, the more satisfied they will be with the treatment. That'll also lead to improved hospital rating. It's pretty linear, those last three, but they all work together and they're all massive. Resisting factors. I'm sorry. This is how we've always done things is a massive one that a lot of nurses that have been on the floor for 30 plus years end up saying, this is how we've always done things. I'm not going to change it because it works decently. As new nurses, I feel like it's our job to kind of introduce a new way of thinking into that. Obviously be a sponge and retain as much information, but maybe think outside the box a little bit as well. You could have decreased effectiveness of affordable treatments. Again, aspirin, increased risk of bleeding, way more than Eliquis. More adverse effects. You could easily mess up your kidneys with just simple aspirin. Eliquis is going to have less side effects. That's objective, but at the end of the day, you got to balance those two things: the affordability versus the effectiveness. Complicated discharge process. You're adding another step into that. Discharge is not an easy thing in the first place. The more complicated it is, the more tricky it will be. That could be a resisting factor, but I think there is ways to streamline it, and that is an entirely different thing on its own. I've went down this rabbit hole and tried to fit it in this slide, but it was a challenge. So we're just going to kind of gloss over that. There is ways to streamline it and just kind of keep that in mind. We talked about it before, increasing nurse workload. Accessibility to care may still be an issue, especially if you're in the rural community. My screen went black. There we go. Accessibility may still be an issue again. Rural people may not have access to care. Insurance may not be able to get in the hospitals, and that's all things that could also have workarounds to them. Who bears the cost? I think if you show people higher up in the hospital that this way leads to less readmission and the fact that you're going to get reimbursed for more stuff because of the lower readmission rate, I think that could be absolutely massive. That's going to be a tricky one. That's going to take a lot of research and a lot of evidence to effectively show that. That's something that won't be done overnight, but it should be worked toward. What other factors could be important in this? This would be an audience question. Who would be the target of this change? This would be an absolutely massive change that would have so many different targets. You'd be targeting the nurse leaders, the doctors, the hospital CEOs, but for the purpose of this presentation, to keep it simple, stupid, you essentially would be targeting the floor nurses and the nurses that are the leaders of the floor in this situation. The change agent. So this is an interesting one as well. For a change of this magnitude to occur, you need many people to participate in the change. There's no way around that. It's a massive deal, but you're going to need a lot of people working with you to make this change. Basically, you're going to want the change agents to be one yourself, obviously, but the formal and informal leaders also on the nursing floor. So you have a senior nursing staff that is loved and respected by all the other nurses. You're going to want to pull them aside and try to convince them, using the evidence that you gain, that this is a good way to do things. Again, formal leaders, you're talking about your charge nurses, your house supervisors, all those people that are just there trying to help as well. You got to try to get them on board, essentially. Working with hospital management will help make these changes beneficial as well. They could be a target for this also. This would be a much farther down the line process, though. Encouraging floor nurses to change. A lot of floor nurses are set in their ways, as you are whenever you're in such a chaotic environment. You end up finding patterns, and however works for you works for you. But there are improvements that could be made, and I don't think anybody would argue any differently than that. You could make it a new hospital policy. This would include talking to some of the higher ups and isn't as big of a deal for this part of the presentation, but it could be a pretty big deal long term, though. Again, convince directors of the hospital. That goes along the same line. Is a big deal, but probably need to be implemented later on. Could lessen workload for the floor nurses by implementing someone to facilitate conversation between patients and providers. This could be a nurse. This could be a social worker. This could be anybody who just goes in and talks to the patient and just makes sure that they can afford their medication. Keep the line of communication open with floor nurses. Give them encouragement. This will help keep them motivated and keep them willing to accept this change. Remain open and flexible to new options. Somebody offers a different solution or some tweak to your plan, be open to it. Don't just shut it down immediately. Try to hear them out and try to incorporate that in if it seems like it'd be feasible. Audience response question again. Who do you think would be the best change agent for this activity? So methods of change. Gather as much information that shows the current rates of patient satisfaction. Present this information to the leaders and discuss the potential new way. This is going to show that the old way isn't the best, and that the new way could be better. Post flyers regarding other things as well. This could just basically remind nurses of exactly what to ask, what needs to be asked, and again remind them that this change is a viable option now in this situation. Create a question checklist for nurses to carry around. This is the same thing, reminding nurses what to ask patients and how this change should be implemented. Again, we end up keep getting back to this point of needing to be open to changes and open to suggestions from other nurses. Change is scary. Being open kind of mitigates that scariness of the change. How to evaluate these changes. Before changes are made, ask about willingness to participate by nurses. Ask if they are able to comply with treatment. Gather as much information as possible regarding readmission rates. After changes are made, you want to track the change or percentage of the patients who feel they can comply with treatment. This could include sending out a survey to patients' homes or whatever and try to get them to respond to that. Try to help this change to become a long-term thing. Look at change in readmission rates also is a big one. Essentially show the difference in groups that are implementing the change and ones that aren't. And that's how you would track that long term. Even a patient satisfaction survey in the hospital before they're discharged. Simple 5-10 questions could get you far on that. Thank you for your time.